Welcome to the lecture series on classifications. Today's topic is pediatric supracondylar humeral fractures. Supracondylar humeral fractures account for 50 to 70% of fractures in children aged between 4 and 10 years. They are divided into extension and flexion types based on the direction of displacement of the distal fragment. Extension type is seen in 95% of the cases. Here, the typical mechanism is falling on an outstretched hand with the elbow in full extension. It causes the olecranon to engage in the olecranon fossa, which acts as a fulcrum. It propagates the force further and causes the distal segment to displace posteriorly. The fracture line propagates from anterior to posterior, with the posterior periosteum being the hinge. Flexion type is seen in 3 to 5% of the cases. The typical mechanism is when a direct anterior force acts against a flexed elbow, which causes anterior displacement of the distal fragment. The fracture line propagates from posterior to anterior, with the anterior periosteum being the hinge. The modified Gartland classification is the most commonly used classification for extension type supracondylar humeral fractures. Type 1 involves minimal displacement. Type 2 is a posteriorly displaced fracture with a posterior cortical contact. Wilkins' modification of type 2 also divides it into rotationally stable and rotationally unstable fractures. Type 3 comprises of a completely displaced fracture with no cortical contact. Type 4 modification of Leak et al. Comprises of a multidirectionally unstable fracture diagnosed intraoperatively. It is unstable in flexion, extension, and rotation due to absence of posterior cortical hinge. Rigault et al. In his article has also mentioned a subtype of supracondylar humeral fractures with medial column comminution. Coming to the second classification, which is the AO classification. The AO classification for supracondylar humeral fractures will always have a prefix of 1-3, where 1 denotes the humerus and 3 denotes the distal segment. Thereafter, it is subclassified into A1, which is an extra-articular avulsion fracture. A2 is extra-articular simple oblique. A3 is extra-articular fragmentary wedge. B1 is partial articular lateral sagittal. B2 is partial articular medial sagittal. B3 is partial articular coronal. Coming to the last subtype, C1 is complete articular simple metaphyseal. C2 is complete articular fragmentary metaphyseal. And C3 is complete articular multifragmentary metaphyseal. Coming to the third classification, which is the Lagrange and Rigault classification. Stage 1 involves undisplaced fractures involving primarily the anterior cortex of the humerus. They are similar to type 1 Gartland fractures. Stage 2 involves fractures with both cortices but with minimal displacement. Stage 3 involves displaced fractures with some contact between the proximal and distal fragment. Stage 4 involves fractures which are severely displaced but no contact between the distal and proximal fragments. They are similar to type 3 Gartland fractures. Stage 5 involves high supracondylar fractures at the metadiaphyseal region. Coming to the last classification, which is the Bahks classification, it is based on the coronal and sagittal orientation of the fracture line. With respect to the coronal orientation, type A is a typical transverse, which has a coronal obliquity of less than 10 degrees. The fracture line starts and ends at the epicortiles at the same level. Type B is a lateral oblique where the coronal obliquity is more than 10 degrees. It starts medially and ends proximally on the lateral cortex. Type C is a medial oblique with a coronal obliquity of more than 10 degrees. It starts laterally and ends proximally on the medial cortex. The last one is type D, which are high fractures which start or end at or above the olecranon fossa but stay in the humeral diaphysis. With respect to the sagittal plane, there are two subtypes. The first one is a low sagittal with obliquity less than 20 degrees, starts anteriorly and ends posteriorly at the same level. The second one is a high sagittal, which are oblique fractures which start anteriorly and exit proximally and posteriorly. These are the references used. Thank you.